Putting down the shades. Welcome, welcome, welcome everyone to our final grand rounds for this year. We're so excited about this. My name's Lori Fitterling, and I'm the course director for Medical Informatics and Information Literacy. And so far this year, we have presented 26 cases in 13 different sessions. It's been an awesome experience for our students, our faculty, and anyone that has been able to share in this presentation. So Grand Rounds is a requirement for our Medical Informatics and Information Literacy course, which is a course for first-year medical students, and it focuses on learning how to find, critically appraise and analyze, and present medical information. These are skills from the core competencies of the entrustable professional activities. So this is our third year of adopting medical informatics for our first-year curriculum. And every year I can say that Grand Rounds has excelled to achieve a higher level, and this year is no exception. This year, for our second semester, we have added a special component. The Research College of Nursing nurse practitioner students have joined with us in an interprofessional collaboration. And we've been very excited about this part of our Grand Rounds. Under the direction of Susan Bennett and her colleagues, nurse practitioner students have joined our groups and have brought a better understanding of team-based care for healthcare providers. Today we have a couple of special guests from the Research College of Nursing. I'd like to introduce them. President Nancy DiBasio and Dean Julie Nauser. And if you two could stand, along with Susan Bennett, let's continue giving them a round of applause in thanking them for their contribution here. I'd also like to take a minute to thank Dr. Amanda Jo Hirsch for moderating our question and answer session today. She's been key. And all of our faculty mentors that contribute to this Grand Rounds case presentation. Thank you all so much. And now I would like to present Group 27, giving their final presentation for Grand Rounds.
Good morning. Can you all hear me? No? Hello, hello. Better? All right. Good morning and welcome to Grand Rounds. I'm student Dr. Jesse Rincon and I'm pleased to represent Group 27. This morning we'll be discussing a case of a 60-year-old woman with worsening neuropsychiatric symptoms. These are the members of Group 27, and I want to thank each and every one of them for their time and dedication into researching this case. And I'll be discussing some of the clinical presentations, our differential diagnoses, and our final diagnosis. Our patient is a 60-year-old female from northeastern India who currently has been traveling back and forth from the United Kingdom for the past 20 years because her husband lives in the United Kingdom. She presents with abnormal behavior, she's been irritable, she's disoriented to time and place, and she's become increasingly forgetful. Now, her symptoms have rapidly progressed over the course of 3 months, and now, unfortunately, she's unable to walk, which has led to repeated falls. She also unfortunately, has lost the ability to recognize her immediate family. And because of that, her family members are very concerned. She is a vegetarian, but she's also lost the ability to feed herself. And her family mentioned that she has had no recent blood transfusions. Now, looking into our patient's history, there's no significant past medical history. She's had no recent surgeries. She's not currently on any medications, and there are no known drug allergies. She is 10 years post-menopause. She's a married woman with 2 children, and her family history is significant for cardiovascular disease. Both parents passed away. When we took her vitals, we found nothing that jumped out at us. Her heart rate, BP, respiratory rate, and temperature all came back within the normal range. Now, upon physical exam, we find a well-nourished, well-developed individual who is alert and oriented to a person. She was able to respond to her name, but she is disoriented to time and place. And when prompted, she's unable to recognize, again, her family. The patient now requires assistance for mobility. Now, after conducting a cardiovascular and pulmonary exam, we found that they both came back normal. HEENT, we found normal cephalic atraumatic with no lymphadenopathy, no thyromegaly. GI exam, we heard bowel sounds in all 4 quadrants and no sign of hepatosplenomegaly. No signs of jaundice or pallor, and after a genitourinary exam, we found she was incontinent of urine and stool. Now, she was able to respond to commands, but her attention is limited at this time, and her speech is slurred, so we really wanted to pay attention to her neurologic exam. After testing cranial nerves 2 through 12, we found they were grossly intact bilaterally. She does have recent and remote memory impairment. We tested her deep tendon reflexes and rated them a 3 out of 4. They were brisk but symmetrical. She does respond to pain, but she's unable to complete the rest of the sensory exam due to her current condition. Now, she's also presenting with myoclonic jerks, which you can see here in this short video. It's this intermittent jerking movement of her limbs. We also noted upon physical examination that there were no sign of meningeal irritation. So due to our patient's presentation, we ordered labs. We ordered a CBC, a CMP. Both came back within normal limits. We looked at her ammonia levels to see if there's any liver issues. Both came back within normal limits. We looked at her seroplasmin levels to look for any potential for Wilson's disease. That came back within normal limits. Thyroid and parathyroid labs came back within normal limits. And it was important for us to really look into the parathyroid lab because of her intermittent jerking movements. We weren't sure if there was a calcium component to her neurologic state. We also performed autoimmune workup to evaluate any possible autoimmune component. We looked at her ANA, ANCA, and her anti-DS DNA. Now, because of the rapid progression, we ordered an extensive workup to ensure we missed absolutely nothing. We ordered an EKG with echo, a CT of her chest and abdomen, a chest x-ray, all came back normal. We also ordered a metal tox screen for arsenic, lead, and mercury to rule out the potential for metallosis. That came back negative. Her MRI also came back normal, and her EEG is currently pending. Now, this led us to 4 differential diagnoses: vitamin B12 deficiency, HIV encephalopathy, viral meningoencephalitis, and Creutzfeldt-Jakob disease. Vitamin B12 deficiency can be devastating. We know that vitamin B12 is important in many biological mechanisms, especially for the cells to synthesize myelin in cell membranes. Now, typically, you would see a patient presenting with low serum B12 levels and unexplained neurological symptoms, including paresthesias, generalized weakness, and even macrocytic anemia. So we wanted to order some labs to rule out vitamin B12 deficiency. Looking at her CBC, it came back normal. And for vitamin B12, we would have seen macrocytic red blood cells, And also her vitamin B12 level and folate levels were normal. Now this is important because vitamin B12 and folate deficiency often coexist and they are hard to distinguish clinically. So we checked both. So we can safely rule out vitamin B12 deficiency. Now HIV encephalopathy was one of our differentials, one because India has a high prevalence of HIV. And typically, it results from damage in the brain due to a long-standing HIV infection. Now, patients can present with many different symptoms, including memory deficits, poor attention, mental slowing, and apathy. And because of this, we wanted to order some labs in order to rule it out. Now, we ordered an ELISA to check for the presence of HIV. That came back negative. We also wanted to screen for any opportunistic infections, including TB and Cryptococcus. Those both came back negative as well. So we feel confident in ruling out HIV encephalopathy. Viral meningoencephalitis is a viral invasion of the central nervous system. Now, patients can have abnormalities in mental status and have signs of meningeal irritation. Typically, you'd see patients presenting with altered mental status, motor and sensory deficits, personality changes, speech and movement disorders, and even seizures, which we noticed in our patient. Some of the key offenders are herpes simplex virus, Coxsackie virus, and echovirus. So there are several ways we can rule this out. We wanted to look at a lumbar puncture for any CSF findings. Herpes simplex virus typically is found in the temporal lobe on an MRI. We also can use a PCR in order to check for any presence of herpes simplex virus. And so when we look at our CSF findings from our patient, we found an acellular CSF with normal glucose and protein levels. Now in viral meningoencephalitis, we would have seen elevated white blood cell count and an elevated protein concentration. We also did a PCR for the herpes simplex virus, and that came back negative. And finally, we have Creutzfeldt-Jakob disease. Now, this is an extremely rare disease. 1 in 1 million are affected, and it's highly lethal. It has a high prevalence in the United Kingdom, and as noted earlier, our patient has been traveling back and forth over the past 20 years to the United Kingdom to visit her husband. Now, one of the things that was really a red flag for us was this rapid progression, which is absolutely characteristic of CJD. And what this is a mutation in a prion protein. And these misfolded prion proteins result in these neurological symptoms, including sleep disturbances, hallucinations, depression, fatigue, progressing dementia, visual loss, memory loss, ataxia. A lot of the very same symptoms our patient is exhibiting. After we obtained our EEG, we saw a very uncharacteristic EEG. On the left here, you're going to see a normal, what a typical EEG should look like, characteristic wave patterns. On the right is our patient's. Oh, pardon me. And what you're seeing here with these arrows indicating are 1 per second periodic sharp wave complexes that are superimposed on a slow background. Now, putting all these pieces together, the EEG, the signs and symptoms, we're confident in saying that our patient has Creutzfeldt-Jakob disease. And now to discuss mechanisms of disease, treatment options, osteopathic manipulative medicine, emerging research, and ethical considerations, I'd like to turn it over to student Dr. Kelly Pauls.
Thank you, student Dr. Rincon. I'm student Dr. Kelly Pauls, and I will be discussing the mechanism of disease, treatment options, OMM, emerging research, and ethical considerations. CJD falls under the umbrella term of transmissible spongiform encephalopathies, which is characterized by diminished brain function, impaired memory, personality changes, and problems controlling movement. There are 4 forms, with sporadic CJD being the most common. The classical sporadic CJD affects adults from ages 50 to 70 years of age, which is relevant as our patient is 60 years of age. It is most common in the United Kingdom, which is also particularly relevant to our patient, as her husband lives in the UK and she visits him from time to time. This disease has an incubation period of 10 to 15 years, but as soon as symptoms have presented, death occurs within the year. As stated previously, CJD is a transmissible spongiform encephalopathy. This is relevant because the prion protein is implicated in this entire class of diseases. Although the prion protein is located at both the pre- and postsynaptic membrane, its function at the presynaptic cell membrane is more relevant to our case. Here, the prion protein is attached to the plasma membrane at the presynaptic cell by a GPI anchor. Its function is not entirely understood, but it's thought to have a role in neuroprotection, neuroplasticity, and neurotransmitter release. Prion protein exists in multiple conformations, with the cellular prion protein carrying out normal synaptic function. Errors in folding of the prion protein can occur spontaneously, with the misfolded prion protein referred to as the scrapie-infected prion protein. If the misfolded proteins are not cleared from the cell, they can accumulate and lead to symptomatology. As seen in these images, the normal protein has a small beta sheet in image A, while the scrapie-infected prion protein has a significantly larger beta sheet motif, seen here. It is this variation in the tertiary structure of the protein that is at the root of symptomatology. Beta sheets lend themselves to aggregation more so than alpha helices, so these scrapie-infected prion proteins can form amyloid plaques. Therefore, not only is the normal function of the prion protein lost, but toxic function has been gained. The accumulation of scrapie-infected prion proteins is shown in this image. A single misfolded prion protein can induce a conformational change in cellular prion proteins. You can see this here, and akinetic mutism. For diagnostic purposes, if at least 2 of those symptoms are observed, a diagnosis of CJD is probable. In addition to noting at least 2 of those symptoms, another component is required for a definitive diagnosis. In our patient, this was an EEG with periodic sharp wave complexes. Other possibilities for a diagnosis would include a characteristically abnormal MRI or a positive 14-3-3 enolase in the CSF. While the typical clinical standards for a diagnosis were stated previously, the gold standard for a CJD diagnosis is obtaining a biopsy of brain tissue. Here, we can compare normal brain tissue in image A with CJD neuronal tissue in image B. The spongiform transformation of the brain tissue seen in image B is characteristic of CJD. This process results in microscopic vacuoles, as seen in this magnified image of a neuron. At present, there are no effective therapies available for CJD. As such, the most current treatment is focused on the symptomatic treatment of the disease. Depending on the patient's symptoms, a wide array of medications may be used. Atypical antipsychotics are used for agitation and hallucination symptoms. Selective serotonin reuptake inhibitors are used for depression symptoms. Anti-epileptic agents are used to treat myoclonus, which is caused by the disease. As our patient was experiencing severe myoclonic jerks, sodium valproate was used as a drug of choice. In our patient's case, OMM relevant to lymphatic drainage may be used. The lymphatic system is a recently discovered lymphatic-like drainage system in the brain. It primarily clears cerebrospinal fluid and interstitial fluid from the brain. This is located within the Virchow-Robin space, which extends from the subarachnoid space and drains into the deep cervical lymph nodes of the neck. As a result, interstitial solutes, such as beta amyloid and tau, are also cleared by this system. This lymphatic system leaves an opportunity to use OMM lymphatic treatments, such as opening the thoracic outlet and the thoracic pump technique. This can possibly improve the quality of our patient's life. However, it is unlikely that OMM will have any effect on the disease process itself due to its long incubation period and rapid progression to death following presentation of symptoms. While CJD currently has no cure, emerging research is vital to further understanding the disease process. Recent research conducted from the University of Texas Health Science Center has attempted to utilize a new non-invasive test for prion contamination of blood, which has 100% specificity and sensitivity. This method uses protein-folded cyclic amplification technique, which is similar to polymerase chain reaction. However, instead of multiplying nucleotides, it uses misfolded prions. While their goal is to detect CJD pre-symptomatically, this is difficult due to the fact that CJD is often diagnosed late and leads to death within a year of symptom presentation. As with any patient that seeks our care, ethical concerns are particularly important to address. One such concern is any possible language or communication barriers. It is relevant to know if our patient is English speaking, and if not, it's best to use a professional medical translation service. While doing so, it is important to directly address our patient as well as any family members present. Additionally, as our patient's symptoms worsen, she will quickly lose the ability to communicate and will ultimately become mute. Determining how to navigate this communication barrier needs to be a priority. As is true with any patient, we also need to consider any relevant religious or cultural concerns on an individual basis. Our patient's background may affect the way in which she pursues treatment or palliative care. Because CJD is a fatal disease with no cure, our patient will ultimately require 24-hour care. This will be burdensome, both financially and psychologically, on our patient and her caregivers. As her husband currently resides in the UK and our patient is in India, it is important to determine who her primary caregiver will be. It is also important to note that our patient's condition will quickly decline to a level at which she is no longer able to make her own medical decisions. As such, it is vital to establish a healthcare power of attorney as soon as possible. I would now like to introduce nurse practitioner student Brandy Sampson to address further patient considerations.
Thank you, student Dr. Kelly Pauls. I'm nurse practitioner student Brandy Sampson, representing Research College of Nursing, and I'm honored to be here collaborating with Kansas City University. Due to CJD's terminal nature, it's important that there is clear communication with our patient and her family regarding expectations on her prognosis. Ensuring the patient has a DPOA and that the patient and family have discussed with the physicians about a do not resuscitate order. Basic assistance will be necessary with feeds, oral hygiene, and activities of daily living. Ensuring that our patient is as comfortable as possible will be a big part of her plan of care. Symptom relief, as discussed by student Dr. Kelly Pauls, monitoring vitals, treating symptoms with pharmacological agents, monitoring skin integrity, assessing swallowing and nutritional status will be a few nursing considerations. Supporting a stable and safe environment for the patient and decreasing the amount of stimuli will help reduce symptoms. Referrals for speech therapy to assist with speech and swallowing needs, dietary for recommendations on caloric intake, Case management to assist the family with options for the future. What will her home care needs be? What assistive devices are needed? What kind of help is available? Case management will assist with these needs and offer information in regards to palliative care, hospice, placement to a skilled nursing facility, or an inpatient hospice facility. Again, treating symptoms and making the patient as comfortable as possible is the end goal. Supporting the family and offering resources for counseling are also very important, as this will be a very trying time for them. We would like to thank the individuals listed for their guidance and support with our presentation. Listed is the bibliography. And thank you. We will now open the floor for questions.
Wow, excellent job. So let's go ahead and start with the questions. If you can do one question apiece, that would be wonderful.
Hello, I'm Andrea Becker. I am a family nurse practitioner student at the Research College of Nursing, and I'm going to field the question, what forms of the transmissible encephalopathy are common in the United Kingdom? Although our patient presented with what seems to be the sporadic form of CJD, the over 200 cases that we know of that have been reported in humans are of the variant form, most of which are in the have been reported in the United Kingdom. This form is thought to be caused by the consumption of meat products contaminated by the bovine spongiform encephalopathy. These patients typically are young and have prominent psychiatric manifestations and ataxia. Their brains will show the spongiform encephalopathy and numerous amyloid plaques. And unlike the sporadic form that we believe our patient had, prion proteins will be detected in the lymphoid tissues. Thank you.
My name is student Dr. James Rapp, and I've got a question here. How do you check for meningeal irritation? So we've got a handful of tests we can do. Neck stiffness is the most important sign of meningitis. So when we're in the clinic, that's what we want to be checking for is neck stiffness. So when the neck is flexed, the inflamed nerve roots and the meninges of the cervical region get stretched. So we've got two tests specifically, Koenig's sign, which involves extending at the knee, basically stretches the lower spinal cord, and then a more sensitive test, Brudzinski's sign, involves simultaneously flexing the neck and the hips, and that's more sensitive because it involves the entire spinal cord rather than just the lower elements.
Hello, my name is student Dr. Taylor Peterson, and I'm answering the question, how do we screen for tuberculosis and cryptococcus when evaluating the possibility of HIV encephalopathy? According to UpToDate, there are two major tests for the identification of tuberculosis infection, the tuberculin skin test and the interferon gamma release assay, both tests evaluating the cell-mediated immunity. To diagnose cryptococcal meningoencephalitis, a lumbar puncture is necessary, although this procedure should be delayed into the setting of focal neurologic signs, papilledema, or impaired mentation, and so we would need to get radiologic imaging first.
Hello, I'm student Dr. Allison Raymond, and I'm answering the question, would a brain biopsy be indicated? The short answer is probably clinically we would need a brain biopsy. However, due to the nature of the disease and infection, we might opt to not do the brain biopsy as we talk with our patient. We have the EEG that indicates CJD with the 1 second spikes, and the main reason we would do a brain biopsy is because our MRI came back normal. However, after talking with the patient and giving them the prognosis, we may opt to not do one or do one, depending on what we discuss with the patient.
Good morning. My name is Ryan Schumacher, and we received a question asking, when was the protein misfolding cyclic amplification technique developed, and how is multiplying prions using this method accomplished? According to an article published in 2012 in the Methods of Molecular Biology journal, This technique was initially developed in the early 2000s, but didn't become fully functional and usable until around 2007. As mentioned by student Dr. Kelly Pauls, this technique has been recently proven to be used to detect diseases caused by misfolded prion proteins like CJD. This technique consists of two phases, and in the first, a small amount of abnormal prions are incubated with a much larger amount of normal prions, and the abnormal prions are able to convert the normal prions to infectious ones, creating growing chains of abnormal prion polymers. The second phase of the laboratory method then consists of blasting those polymers with ultrasound waves, and that's designed to break apart these large polymers and increase the amount of abnormal prion nuclei available to convert other normal prions. This two-step process is repeated over and over again in a process much like the polymerase chain reaction, in which substrate is used to create and multiply templates of the protein of interest, or in our case, prion of interest. Automation, which was developed around 2007 when this technique really became usable, has greatly improved the effectiveness and functionality of the PMCI technique, and in as little as 7 rounds, over a 3 billion fold increase in sensitivity of detection can be accomplished, allowing as small as a single oligomer of infectious prions to be detected, which is well below the threshold required for infection.
Good morning, guys. I'm student Dr. Hassan Siddiqui, and the question I'll be answering is how sodium valproate, which was the medication used in our case, is used to reduce the myoclonic symptoms. So sodium valproate is an anti-epileptic agent, which acts through increasing the levels of the neurotransmitter gamma-aminobutyric acid, or commonly known as GABA, within the synaptic cleft. So in order to accomplish this, the drug acts through upregulating the enzyme known as glutamic acid decarboxylase, which thus leads to increased GABA production. Now, due to its inhibitory nature, elevated GABA levels cause reduced action potential firing into the post-synaptic neurons. And basically, as such, it eventually leads to the reduction of those myoclonic symptoms which our patient was experiencing. Thank you.
Hello, everyone. I am student Dr. Derek Fenn, and I will be answering the following question. How are other forms of Creutzfeldt-Jakob disease transmitted? So the other forms are variant, familial, and iatrogenic. Nurse practitioner Andrea Becker, she already mentioned variant CJD, but just to reiterate, it is linked to bovine spongiform encephalopathy, which is also known as mad cow disease. And this can be transmitted to humans by consuming cattle that had this condition. The next form is familial CJD, which is due to an inherited mutation passed down from parents to offspring. This usually accounts for about 15% of all CJD forms, so it's quite rare. The last form is iatrogenic CJD, which is due to exposure to tissue from an infected individual, usually during medical procedures such as blood transfusion or surgical procedure.
Hello, I'm student Dr. Abi Reddy, and we received a couple questions asking about the ELISA. What is ELISA, and what are you measuring with ELISA? So the ELISA is used to detect and measure antibodies to HIV virus in the patient's blood, or CSF. Most commonly, HIV antigen is attached to a 96-well plate. Then the patient's serum is added to the sample. If the patient is infected with HIV, the immune system will have made antibodies, and these antibodies will attach to the HIV antigen. Then a second antibody is added, and this antibody has color attached to it. And when light is added to the sample now, the colored solution absorbs the light, and the amount of light absorbed is proportional to the amount of antibody initially bound. And usually absorbance or optical density values of greater than 1 in an indirect ELISA are considered a positive test.
Student Dr. Alexander Shin, we received a question on what laboratory tests are available to further confirm CJD. And there was actually a pretty incredible study that was published in December 12, 2016 by a team of MD doctors in Italy. And they're super excited about this because they have found a way to virtually confirm with 100% confidence specificity and sensitivity, the diagnosis of CJD. And the new name of the test is the second generation real-time quaking-induced conversion assay. And they further talked about this test is only going to cost $100 to $200, and the results are going to be made within 1 to 3 days, available to the patient.
All right, let's hear it for group 27. Excellent job. This case was extremely interesting. Correct? Yeah, just nod, smile and nod. All right, so what was really fascinating about it, not just it being about a prion disease, is the fact that this patient had multiple different aspects of her history that we really had to make sure we asked good questions about. So it wasn't just limited to this unique, very foreign kind of disease. It was all about, well, okay, let's take into consider all of the different causes of altered mental status. And that's where that tremendous workup, this excellent workup came through, so we could make sure that we could rule out other neurodegenerative disorders as well as organic and possibly reversible causes of dementia. Also, the geographic location. So sometimes I remember in med school I would get kind of narrow-minded about, it's just me and my little bubble. Nope. That goes away in medicine. So I think it's excellent that you addressed the topic of geographic location in regards to certain diagnoses. Also, the social history. So to get from this patient that she's a vegetarian was extremely important because a B12 was certainly something that we could start being suspicious of. So excellent job there. Um, the Cryptococcus antigen or Cryptococcus testing is, you're right, we need to have imaging behind it before we do it to make sure there's no increased intracranial pressure, but we can do that a couple ways. So after we get the CSF, we can do cryptococcal antigen testing on that. Boards love to ask about India ink staining, so I would keep that in mind. But what I really wanted to thank you for is your excellent hard work and your dedication and your amazing presentation today. Nurse practitioner students as well. I mean, on top of clinics, you're here, you're collaborating, and you're providing this superior kind of information that is just an excellent addition to these grand round presentations. So hopefully you can take some pride in your tremendous accomplishment. Thank you all so much for being such a great representatives of KCU, and let's get the next group up. So
Hi, this is I would like to have a short announcement because that's very relevant. We have a Science Friday talk, and then Dr. Randall Hoffman from the Stowers Institute will come and then give us a talk about the protein misfolding, and then especially for the prions. So for those who are really interested in to increase their knowledge about the protein misfolding, a more biochemical aspect, you are most welcome. Just watch out, the announcement will be placed in the intranet. Thank you.
Good morning. Can you? Is it on? Let's see. Good morning, everyone. And on behalf of Group 28, welcome to Grand Rounds. Today, we will be discussing the case titled "Something is Off in This Elderly Man." These are the members of Group 28, which consist of students from the Research College of Nursing as well as KCU. I'm student Dr. Samantha Tran, and I will begin by discussing the patient's history and physical exam, as well as potential differential diagnoses based on the patient's presentation. Our patient is a 73-year-old male who presented to the emergency department with a 3-day history of mild headaches and drowsiness. His wife stated that he'd been napping more frequently, had a poor appetite, and overall just seemed a little bit off. He denied any history of trauma, such as falls, and reported no seizures or focal neurological deficits. Our patient's past medical history and surgical history are unremarkable, and our patient is married, retired, drinks about 5 to 6 ounces of liquor each day. He neither smokes nor uses recreational drugs, and he stated that he does not exercise regularly. Our patient stated that he takes a baby aspirin daily, however didn't specify the reason, and he has no known drug allergies. When we assessed the patient's vital signs, they were all found to be within normal limits, other than an elevated blood pressure. Next, we began the physical exam with a symptomatic review of the ENT, cardiovascular, pulmonary, and GI systems. In general, our patient appeared well. However, when answering questions, he was unfocused and gave vague answers. Upon examination of the ENT system, fundoscopy was seen to be normal. Additionally, the cardiovascular, pulmonary, and GI exams were unremarkable. A detailed cranial nerve exam was conducted and did not demonstrate any abnormalities. Cerebellar function tests were normal, as were motor and sensory examinations in all 4 limbs, except for a hyperreflexive biceps and patellar tendon. His Glasgow Coma Scale was also found to be 15. Pronator drift and Romberg tests were conducted, both of which led to negative results. As seen in the image on the slide, pronator drift tests for upper motor neuron disorders. The patients asked to hold their hands up, palms up, and close their eyes as seen in image A. A positive sign would be pronation, which you see in image B, and this is indicative of weak supinators. Romberg sign tests balance. Assessing the dorsal column of the spinal cord, the patient is instructed to close their eyes while standing, and a positive sign would be a loss of balance. Based on the patient's signs and symptoms, we proposed 4 differential diagnoses: an intracranial tumor, subarachnoid hemorrhage, hepatic encephalopathy, and a subdural hematoma. To assess these differential diagnoses, the following laboratory tests were initiated, all of which yielded results that were within normal limits, except for electrolyte levels, which were found to be within normal limits except for decreased sodium levels. A head CT was also conducted on our patient. Our first differential diagnosis is an intracranial tumor. Brain tumors may originate from neural elements within the brain as either individual cell mutations or genetic mutations. They can also be caused because of metastasis of distant cancers. Patients with intracranial tumors will also often present with headache, altered mental status, ataxia, weakness, and gait disturbances. Patients with intracranial tumors commonly also have bleeding disturbances, metabolic disorders, and excessive hormone production, which would be seen as abnormal lab results. Therefore, to further assess for the potential of an intracranial tumor, a coagulation study and a complete metabolic panel would be necessary. Though these tests were not done on our patient, the other lab results were within normal limits. And in the case of an intracranial tumor, a chemical workup is less important than CT imaging. On CT imaging, intracranial tumors will be seen as in this image on your left, a clear intracranial mass. This doesn't resemble our patient's CT, which is here on the right. Instead, the suspected lesion on our patient's CT is noted on the right side and appears hypodense to isodense compared to the surrounding parenchyma. Though our patient did present with a headache and altered mental status, when comparing the other signs and symptoms of an intracranial tumor, with those of our patient, it doesn't suggest that our patient had an intracranial tumor, and we can therefore rule out that differential diagnosis. Our next potential differential diagnosis is a subarachnoid hemorrhage. A subarachnoid hemorrhage is caused by a rupture of an artery in the subarachnoid space, which is between the pia and arachnoid mater. The arteries of the circle of Willis are particularly vulnerable, especially the middle cerebral and anterior communicating arteries. Subarachnoid hemorrhages can be the result of head trauma, but it's most common in people with weak arterial structure, such as elderly or diabetic patients, by manner of spontaneous vascular events such as aneurysms. The first symptoms patients will encounter is a sudden and very severe headache. This can be followed by nausea, vomiting, and dizziness. Another sign of subarachnoid hemorrhage is papilledema, which is swelling of the optic disc that's associated with increased intracranial pressure. With these indications, an urgent non-contrast CT should be done, followed by lumbar puncture in order to diagnose the problem. The lumbar puncture is performed in order to assess for blood in the CSF, which can lead to xanthochromia. This is seen in the test tube on the right and is a telltale sign of subarachnoid hemorrhage. A subarachnoid hemorrhage can be identified by bright white areas in the brain in a non-contrast CT, as seen here on the image in your left. Though our patient does show signs of increased intracranial pressure, his CT does not have bright white areas as seen in a subarachnoid hemorrhage. In addition to the fact that the CT image does not indicate a subarachnoid hemorrhage, because the patient's fundoscopy was normal, we can conclude that there was no papilledema. Thus, we can rule out the differential diagnosis of a subarachnoid hemorrhage. Next, we will be assessing the possibility of hepatic encephalopathy, which is commonly associated with liver disease. The encephalopathy is caused by the accumulation of toxins in the bloodstream that are normally removed by the liver and can result in brain edema. This is a possible diagnosis for our patient due to his history of drinking 5 to 6 ounces of liquor daily. Alcoholism can lead to liver disease, thereby potentially leading to hepatic encephalopathy. Common symptoms include sleep disturbances, confusion, altered levels of consciousness, and in the more advanced cases, coma. Due to liver failure, patients with hepatic encephalopathy are likely to have elevated LFTs and ammonia levels, so we would need to carry out these 2 lab tests. A CT scan of the brain is usually done to rule out any other possible causes of altered mental status, and an abdominal CT would be conducted to examine the liver. Psychometric tests quantify the impairment of mental function in patients with mild stages of hepatic encephalopathy. However, use of these tests can be cumbersome and are often nonspecific to certain diseases. Due to the fact that our patient's lab tests were within normal limits, our patient's abnormal head CT, we decided that hepatic encephalopathy is not our final diagnosis. Rather, upon a detailed review of our patient's CT scan, signs and symptoms, we concluded that our patient presented with a subdural hematoma. A common cause of subdural hematomas is a rapid acceleration of the head along an angular or linear axis, usually accompanied by swift deceleration. These sharp movements can lead to brain trauma. Low amounts of CSF can also lead to decreased buoyancy of the brain, which increases the amount of force exerted on the brain during movement and can apply increased traction on those blood vessels. Additional risk factors include atrophy of the brain due to age and chronic alcohol abuse, as well as the use of antithrombotic agents. These risk factors are particularly significant in the case of our patient because he's 73 years old, drinks about 5 to 6 ounces of liquor daily, and takes a baby aspirin each day. Subdural hematomas are more common in men, and symptoms may include painful headaches, lightheadedness, cognitive impairments, and focal deficits. In this particular type of hematoma, the bleeding occurs in the subdural space, which is between the dura mater and the arachnoid mater, as seen here. Usually, this is due to the rupture of bridging veins that drain the superficial brain into the dural sinus. However, 20 to 30% of cases are caused by ruptured arteries that are less than 1 millimeter in diameter. Subdural hematomas tend to be slow and progressive in nature. It can take up to a few weeks for symptoms to be visible due to the low pressure in ruptured veins. Furthermore, unlike epidural hematomas, subdural hematomas do not appear crescent-shaped as they're not bound by suture lines. Subdural hematomas present as problematic when they compress and translate the brain in a given direction, which can lead to a herniation. A falx herniation would indicate compression of the brain laterally, presenting with a midline shift on the CT scan, whereas an uncal herniation leads to the compression of the brain inferiorly through the tentorial notch, which in severe cases can fatally compress the brainstem. Here we see our patient's CT. The brain is noted to be asymmetric with a suspected lesion on the right. There are signs of increased intracranial pressure, including effacement of the right-sided ventricles, obliteration of the right sulci, and a midline shift. The brain parenchyma on the left is also noted to be atrophic with prominent sulci. All of these signs are indicative of a subdural hematoma and therefore lead us to our final diagnosis. Next, I would like to introduce student Dr. Kelsey Soppet, who will be discussing the treatment, OMM considerations, ethical considerations, and emerging research regarding subdural hematomas.
Thank you, student Dr. Tran. Hello, I'm student Dr. Kelsey Soppet, and I will discuss the treatment, OMM, and ethical considerations and emerging research in our case. As stated previously, based on our diagnostic tests and deductive reasoning, we concluded that our patient had a subacute or chronic subdural hematoma. Recommended treatment is a surgical intervention for patients with a clot of greater than 10 millimeters or a midline shift of greater than 5 millimeters. Furthermore, surgery is recommended if the Glasgow Coma Scale, or GCS score, decreases by greater than or equal to 2 points between onset of injury and hospital admission. If the patient presents with asymmetric, fixed, or dilated pupils, this also necessitates surgical intervention. The optimal treatment for a subdermal hematoma is slightly controversial. Although better results are seen with craniotomy, most experts feel a burr hole evacuation should be the primary approach to avoid risks associated with formal craniotomy. We determined a burr hole evacuation was the most appropriate treatment for our patient. Excellent. During this procedure, the surgeon makes one frontal and one parietal burr hole, both of which are just superior to the superior temporal line. The dura and outer membrane of the hematoma are incised, releasing hematoma fluid, classically described as engine oil, due to its color and viscosity, as you can see here. The need for 2 burr hole incisions does raise the risk of infection. However, standard sterile surgical techniques have successfully kept infection rates at a minimum. Once the hematoma is drained, the subdural collection cavity is irrigated liberally with saline solution, which the surgeon will demonstrate in a minute. The surgeon will continue irrigation until the effluent runs clear, which can be observed in the frontal burr hole by the drainage you see. The procedure is converted to open craniotomy if the hematoma is too congealed for irrigation drainage, if the complex of membranes prevents effective drainage, or if persistent hemorrhage occurs that cannot be reached through the burr hole. The required surgical prepping should always be done prior to starting the burr hole procedure, in case conversion to a craniotomy is indicated. A soft silicone drain is then inserted into the subdural space via the frontal burr hole. Subdural drains can be left in place for 1 to 2 days, and mild hydration and bed rest may encourage brain decompression back to its original size. Current mortality rates for subdural hematomas are between 40 to 60% for all cases. Prognosis for subdural hematomas is determined by numerous factors, including age, presenting neurologic condition, midline shift, and promptness of surgical intervention. Therefore, this statistic is variable dependent on the specific patient and their presentation, with the strongest prognostic indicators being age and GCS. The patient in this case was successfully treated with burr hole evacuation. of that hematoma and returned to his baseline neurologic status. He suffered no postoperative complications and was discharged to home 4 days later. Unfortunately, osteopathic manipulative medicine is contraindicated in our patient. Despite the obvious concerns of manipulating the head postoperatively, blood pressure also must be monitored very closely. OMM has been shown to affect blood pressure, typically lowering it, but regardless, any change at this stage could have negative ramifications. Ethically, it is our duty to address any excessive alcohol consumption with this patient. Our patient admitted to drinking 5 to 6 ounces of liquor daily, which does put him in a high-risk category. The literature indicates that alcoholism contributes to subdural hematoma and must be evaluated in order to best serve our patient. We should also screen the patient for elder abuse at home to further assess his healing environment. By addressing these concerns, we are eliminating any possibility of unconscious bias due to assumptions we might make based on his age, gender, identity, race, or perceived family dynamic. Because subdural hematomas are prevalent and recurrent primarily in the elderly populations, current research is aimed towards less invasive surgical procedures. Emerging pharmaceutical research is focused on preventative intervention to combat recurrence and promote healing. One such emerging treatment is the subdural evacuating port system, which involves administering one burr hole localized to the site of trauma. The hematoma is then drained utilizing a pump and negative pressure system. It is much less invasive than craniotomies, with success rates equivalent or approximately equal to the leading surgical interventions, with 73% of patients showing clinical improvement postoperatively and 78% of patients returning to their baseline neurologic status. Tranexamic acid is a pharmaceutical treatment currently being researched. It is an antifibrinolytic agent used to minimize bleeding of trauma patients. Ongoing clinical trials are evaluating the rate of chronic subdural hematoma resolution. Although results are not formalized, findings indicate a lower rate of recurrence of the subdural hematomas while improving likelihood of chronic resolution. Atorvastatin is another medication actively being researched for treatment of the disease. Atorvastatin is a cholesterol-reducing medication and is reported to promote angiogenesis and suppress inflammation. This drug therapy is undergoing double-blind clinical trials at the moment. To discuss provider considerations and patient education, I now present student nurse practitioner Sarah Fairchild.
Thank you, student Dr. Soppet. My name is student nurse practitioner Sarah Fairchild. I will be presenting from Research College of Nursing. I'll be going over provider considerations, patient considerations, as well as education. Positioning and safety is important not only in the hospital, but also in the home. Hospital positioning and safety is having the head of the bed elevated 30 degrees higher. Head positioning based off of intracranial pressure is necessary. The head needs to be positioned midline. And if the patient needs to be repositioned or moved in any way, the log roll technique is used. Seizure precautions also need to be in place as well. These include having pad side rails in place, as well as not leaving the patient alone or unattended. Home positioning and safety. Watching for areas of activities that increase the risk of falls. To be aware of medications that the patient may be on that may alter the patient's balance, mobility, and coagulation states. In this patient specifically, it is imperative to be cognizant of alcohol use as well as alcohol withdrawal. Education for risk factors, seizures. For this patient, it is not pertinent because there were no reported seizures in this patient. History of trauma or falls. In this patient, it is not pertinent because there were no reported falls or trauma. This patient is 73 years old, and he is elderly, and he is at risk for atrophy. So even mild trauma can result in tears, because of the bridging vessels are at a greater length and have a higher incidence and probability of susceptible shearing. This patient has had a history of headaches and somnolence over the last 3 days. History of headaches and gradual cognitive impairment is also a risk factor. History of long-term alcohol abuse or use is a risk factor. This patient has a specific 5 to 6 ounce hard alcohol consumption per day. Medications are also a risk factor. Anticoagulation and antiplatelet medications. This patient uses aspirin 81 milligrams daily. This inhibits platelet aggregation and can prolong bleeding time. Education for follow-up. Don't delay in care. Call 911 and activate the emergency response system if there's any concerns. Reportable signs and symptoms include headache, nausea, slurred speech, double vision, increase in lethargy, decrease in consciousness, incontinence, seizures, and altered motor function. Follow-up should be routinely managed by both primary care and specialty healthcare providers to provide an intercollaborative approach to this patient's care. Education on prevention of subdural hematomas would be to make sure that the home is clear of any hazards such as rugs, cords, and anything obstructing the walkway or mobility of the patient. Use of assisted devices when ambulating is necessary, such as canes, walkers, and assisted devices. It would also be imperative to educate the patient on decreasing the alcohol consumption and to have regular eye exams. This patient doesn't have any physical activity, so implementing that into his daily lifestyle would be important. Lastly, emotional liability should be addressed. Depression in patients after a subdural hematoma can occur. A depressive state further coupled with alcohol use could lead to detrimental outcomes in patients like these. There are also caregiver stressors. Exhaustion, anger, guilt, and rage can also place additional strain on caregivers, which can therefore lead to potential abuse in the home. This concludes our final presentation at Grand Rounds. Thank you. We'd also like to extend a thank you to the following. And we are open for questions. Thank you.
Now that is how you grand rounds. All right, so we've had some excellent questions from our audience and online viewers come up throughout the presentation. So, Kathy, you want to start us off?
Hi, I'm student Dr. Kathy Yu. I will be answering the question, what is the Cushing reflex? So the Cushing reflex is a hypothalamic response to brain ischemia, which causes the sympathetic nervous system to be activated. This leads to increased peripheral vascular resistance, which causes an increase in blood pressure. The increased blood pressure then activates the parasympathetic nervous system via the carotid artery baroreceptors, resulting in vagal-induced bradycardia. The brain ischemia that leads to the Cushing's reflex is usually due to the poor perfusion that results from increased intracranial pressure.
All right, my name is student Dr. Jordan Sotis, and I just have a question here. Can a subdural hematoma be treated without surgery? And short answer is yes, it can be. It's actually recommended for patients with a clot that's less than 10 millimeters or that have a midline shift of less than 5 millimeters on the CT. And however, you do need to monitor them because the hematomas can become larger and more dangerous. So it's important to monitor for increases in intracranial pressure, perform serial brain imaging, and monitor for worsening in neurological status. There's actually several authors that advocate for conservative treatment in elderly patients who have no evidence of increased intracranial pressure, even if they do have worsened neurological symptoms. And they actually had a study where they followed 5 70-year-old patients or older. And after about a month to 45 days, all of those patients showed complete disappearance or marked reduction in the size of the subdural hematoma, and they showed neurological recovery as well.
My name is Molly Davidson. I'm an NP student. We had a question about cerebellar function, and it does coordination and proprioception. So you can sometimes just watch the patient walk around and detect deficits, but there's two tests specific in the NIH stroke scale, which is why I'm standing up here so you can see them. The heel to shin, and then also finger to nose. If you're the demonstrate or performer, or I don't know, what word am I looking for? Physician or tester, you want to make sure that you hold your finger out far enough for the patient to have to extend all the way. Otherwise, you might not detect any ataxia. All right, tips and tricks.
Now is it on? Hi, everybody. My name is Alex Stein. I'm going to be fielding the question of what is the recurrence of subdural hematoma. Two things to consider is whether you're talking about chronic or acute. When you're talking about chronic subdural hematoma recurrence, it's described in up to 5 to 30% of patients. Use of postoperative drainage is associated with a lower risk of secondary recurrence. Older age, thicker hematoma width, bilateral presentation have been linked to higher rates of recurrence. Ongoing antiplatelet and anticoagulant therapy is also likely going to cause a risk of increase of recurrent. SDH has been found with SDH risk in general, although it's not been consistently found. On the other hand, if you consider acute subdural hematomas, which we did not talk about today, it appears to be a relatively rare event to have a recurrence of that. It's usually found associated with an underlying fixed bleeding source, such as dural arteriovenous malformation, arteriovenous malformation, metastases, or intracranial hypotension.
Hi everyone, my name is student Dr. Caroline Ward, and I received the question, what is the role of ammonia in the pathogenesis of hepatic encephalopathy? And according to Medscape, ammonia has multiple neurotoxic effects. It can alter the transit of amino acids, water, and electrolytes across astrocytes and neurons. It can impair amino acid metabolism and energy utilization in the brain. Ammonia can also inhibit the generation of excitatory and inhibitory postsynaptic potentials. Inflammation in conjunction with the ammonia can also appears to play a role in the hepatic encephalopathy. Patients with cirrhosis. This may indicate that different types of anti-inflammatory therapy can be a potential therapeutic approach.
Hello everyone, I'm student Dr. Tyler Vealing, and I received the question asking, does taking an aspirin routine put a person at an increased risk for subdural hematoma? According to UpToDate, the incidence of a subdural hematoma during aspirin therapy is only slightly increased when compared to those who are not taking any other kind of blood thinner. This varies widely though, depending on the age and lifestyle of that person. With that said, even though aspirin only slightly increases the risk of actual subdural hematoma occurrence, it is still a blood thinning drug and it can have serious repercussions should any vascular event actually occur.
Hi, I'm student Dr. Weston Zagraf. The question I got was, how are focal deficits caused by subdural hematomas? According to UpToDate, global deficits are more common than focal deficits, and the global deficits they suggest are disturbances in consciousness, but you can have focal deficits depending on where the hematoma is. It says contralateral hemiparalysis can occur as a result of direct compression of cortex underlying the hematoma, and ipsilateral hemiparalysis can occur with lateral displacement of the midbrain caused by the mass effect of the hematoma. The midbrain is displaced laterally, the cerebral peduncle into the tentorial notch, and can cause focal deficits.
Hi, I'm student Dr. Tavin Tempercorncrow, and the question I received online was, what would be the timing of surgery for a patient diagnosed with subdural hematoma? The answer to that question can be varies. It depends from a case-by-case presentation of the patient. But according to UpToDate and observational studies suggested that surgery within 2 to 4 hours after the onset of neurologic deterioration in patient with subdural hematoma is associated with lower mortality and then delayed surgery. These studies report mortality rate between 30 and 47% if surgery was performed within 2 to 4 hours of deterioration. This generally characterized by a decreasing GCS score or emergence of new focal findings such as papillary asymmetry or posturing. However, mortality rate went up to about 80 to 90% when intervention was delayed beyond 2 to 4 hours. Thank you.
Hi, my name is student Dr. Minjo Chung, and we have a couple of questions here that basically ask the same thing. So why do we have craniotomies, burr hole, as well as the subdural evacuating port system? Essentially, what's the difference? So with craniotomy, you're cutting a hole in the skull. So usually we like to avoid that if there's, better methods. And with the burr holes, you're drilling two holes, which are usually 14 millimeter in diameter. Whereas with the port system, you're only using one hole that has a 5 millimeter diameter. So basically, what you're just the difference is that you're just trying to minimize how invasive the procedure is, so you can minimize the chance of infection. And that's it.
All right, let's give him another round of applause. So just as a reminder, these are first-year medical students that have been getting Medscape cases, and they put them into a formal presentation. And of course, we're joined by our wonderful nurse practitioner students. But there's been some faculty mentorship along the way, and I just wanted to highlight a couple of the faculty. It's my pleasure and honor to give a big thank you to Dr. Dobson, Dr. Lopez Hernandez, Dr. McCormick, Dr. Ballum, Dr. Johnston, Dr. Johnson, Dr. Randolph, and Dr. Zadie. It has been an absolute pleasure. Also, of course, how can you forget Lori Fitterling? Without you, Grand Rounds would not be as exceptional as it is. Lori, can we give them a round of applause, please? Wow, I can't think of two better cases to kind of seal the deal on Grand Rounds for this year. I just want to thank you all so much for such an excellent presentation and for a wonderful Q&A session as well. Thank you so much for taking the time in detail to make sure that we did a thorough history as well as presentation. Brain bleeds are extremely common. So to get a good history can really point us down which one it is. To look at the imaging can also help us determine which is most likely. And Sarah, I think you did an excellent job really highlighting a lot of points that we have to be cognizant of when we're really taking the patient care into perspective. So that's good for us practitioners to know, but also family members to know. And the alcoholism was brought up multiple times during this presentation, and I appreciate that. And as providers, we're also going to have to make sure that if we do admit this patient, we'll have to put them on a CWAP protocol. So a CWAP protocol is essentially some questions, signs, and symptoms that we look for, and then we can help address that patient's withdrawal accordingly. All right, so just a fantastic job today. I am extremely proud of you. Just fantastic. One reminder is Dr. Desai will be up at noon doing a panel with medical students that had traveled to Africa next year, so make sure if you're available to stick around for that. And it is an appropriate venue. All of you have been through Grand Rounds at this point, correct? Take a look next to the person sitting next to you and make sure you tell them what a great job they did this year. Because on top of your coursework, on top of your rigors, your studies, your labs, you did this. And you made KCU look fantastic. So make sure you thank yourself and appreciate all of your many accomplishments that you've had this year.